consultant cardiology at our in United Kingdom. She'll present one case have to do with electrophysiology, as I understood it. She would refer to have the questions in the middle of the presentation. So whoever have questions, please send it through. تفضل دكتورة نادية.
شكرا. السلام عليكم للجميع. وحبيت نعيد عليكم although هي قبل العيد، لكن كل سنة وانتم طيبين، وإن شاء الله ربي يدوم على الناس الصحة والعافية وراحة البال ويهدي السر. حبيت نقدم حالات on syncope. Syncope is a very common problem that we see in the cardiology, and for me, being an electrophysiologist, I see highly in my clinics. Syncope, even in general clinics, constitutes about 10% of clinic attendance, and in the UK, 6% of emergency department attendance is related to syncope. So my first case is relating to a 49-year-old male, very active chap, no contributory medical history of note, first attack of repeated syncope and near syncope, which happened in succession repeatedly in one day. At the time, he was exertional, so he was playing a game of hockey and felt during the exersion very unwell and had to retreat to the benches. And this was his ECG on the attendance of the emergency medical team. Of note, his clinical examination and vital signs were normal, and he has no family history and no high-risk markers that we look for, especially in the electrophysiology clinics. So this is his ECG. I want you to cast an eye and have a look at his ECG, because the next slide asks a question relating to the ECG. So this ECG, in your opinion, shows first degree AV block, pre-excitation, high-grade AV block, normal, none of the above. So go back to the ECG, and if Dr. Fethi, you could open the polls, please, for voting. So can everyone hear me okay? Okay, so I'm going to go back to give people a chance to look at the ECG. Apologies, it's a photocopy, يعني صورة للECG, so sometimes it doesn't portray very nicely as the original. Okay, so is the voting over, Dr. Fethi? I've lost my slides. Could I please have the screen with my slides back? So for most people that I've seen who have voted and have commented that the ECG is normal, and in fact, yes, it is normal. And it's probably important to recognize a normal ECG, because a lot of the time we tend to look for hidden abnormalities, and sometimes we actually make up things that aren't there. So it's important to recognize a normal ECG as is an abnormal ECG. So indeed, I agree with most of the participants that the ECG is normal. So with this in mind, we had someone who's exertional, feeling syncopal, pre-syncopal during exertion. We think of exercise-induced ventricular arrhythmias, something like catecholinergic polymorphic ventricular tachycardia. So these are things that go through one's head. But in fact, when the patient attended to hospital and we had him on telemetry and monitoring, this is what we saw. So you can appreciate on the top part of the screen, you see that he starts off with, people are still voting. We had the survey come up, so in the top part of the screen, we see here that the ECG, we have about a minute recording, almost, on the top part of the screen. And this is continuous telemetry. And we see that in the top part of the screen, the sinus rhythm kind of slows. And then we develop what I've enlarged and portrayed for you in the bottom of the screen. So in the bottom of the screen, we have 3 leads that I've blown up and enlarged. Lead 1, lead 2, and V1, 2, and lead 3. And you can appreciate that the heart rate gradually slows, and then we develop a change in rhythm, a change in conduction rather than rhythm, and then eventually we see the middle part of the screen, and then there is conduction returning. So before I say too much, I wanted to enlarge the screen for you to have a look. And the top part shows lead 2. This is another episode. So this is something that was happening repeatedly with this gentleman. And the bottom part of the screen here is the enlargement that I showed you on the last picture. So I'm going to ask a question here, and we'll go back to have a look at it. So would you place a temporary pacing wire for this type of conduction abnormality that you've seen? So I'm going to go back to the original screen here, and I'm going to show you here that this episode here is lasting for a couple of seconds. Here we see probably about 25 to 30 seconds. And I don't know if you can actually see my pencil here, but this we see here, sinus rate is slowing. We see here that the conduction then alters, and we see here complete ventricular standstill or complete AV block. And this is probably lasting for about 20 to 25 seconds, and this is happening repeatedly. And at this stage, we have not completed our investigations. So we'll talk about the findings, but would you place a temporary transvenous pacing wire? And I'll allow the polls, if Dr. Fethi could open the polls, please. So yes, if you would, no, if you didn't, and don't know if you're not sure. And all these episodes are happening very transiently. So allow a few seconds for the voting to happen. And we're at this stage where this gentleman is just presented. He's not in this rhythm at all the time. It is recurring. And we are yet to establish a diagnosis, but we have a bit of an idea of what it may be, or a differential. So that's very interesting. So about 40% of the participants said yes, they would. Another 40% said they wouldn't. And about 10 or 11% said they didn't know. And he's 49-year-old, with the 49 being the new 29 in the Western world. So he's a 49-year-old fit chap, drives a pickup fork as a worker that lifts heavy equipment, so a kind of tractor type thing. He's 49-year-old. So the question was, would you place a temporary pacing wire? And I'll go back and just talk a little bit about this, these ECGs. So as you see up in the top hand screen here, we start off with a sinus rate probably within normal. Very little prodrome, he describes, but as this episode happened, he had started to recognize and say, look, it's happening, and then within a couple of seconds he's out, and showing some signs of convulsion or jerkingness, and then recovers again. So this starts off with a sinus rhythm that becomes a sinus bradycardia, and then we see it develops into a second, it develops into a 2-to-1 AV block, 2-to-1 AV block, and then we see complete AV block with ventricular standstill, and then we see escape beats here that are probably infranodal, and then we see recurrence of conduction originally to start off with 2-to-1. So on the ECGs, and we see here, if we map them out on the top hand screen, here we see a PR interval that's probably approaching 200 milliseconds at the top here, and it's a 2-to-1 block here that we see. This is conducted and this isn't. But then there's prolongation here with a PR interval of 280 milliseconds, and this is conducted and this isn't. So almost like a winky back. But then you see that there's a beat which is exactly the same as this beat here in morphology, and the P wave is just going through. So we see the P to P interval here is in the region of 1, 2, 3, 4, 5. Let's see, get my pencil. So PP interval here is 1, 2, 3, 4, 5, 6, almost 7. So the PP interval here is probably about 35 beats per minute, the PP interval, or the sinus rate. And we see the Q interval here is something like in the 20s, 23. So the P to P interval here doesn't match the Q to Q interval here, but then we see it changes. And if we look at the bottom screen here, mapping out the P to P interval, can people see my pencil all right? If you can, could you please put a yes? Okay, so the P to P interval here, we map at about 1200 milliseconds, and 1200 milliseconds equates to almost about 50 beats a minute. And as we see the gradual prolongation of the P to P interval, we see it's gradually slowing. The PR interval is changing a little bit, not that much. And then we see again that the P to P interval is prolonging, and here 1395, so almost 1400 milliseconds. And then we see that the P to P interval here, even when there is ventricular standstill, the P to P interval is still prolonging. So it's going down to 37 beats a minute, which is 1600 milliseconds, and again down to 1800 milliseconds, which is 33. This is the sinus rate that's varying at a low rate. The ventricular rate is not conducting to the ventricle because it's complete AV block. So you're going to have to take my word for it that we did a couple of investigations and they all came back normal, including echocardiography, including cardiac MRI, and cerebral MRI, brain MRI. We did a PET scan, blood tests, and serology. And the important investigations to point out in people that are kind of a youngish age, and sometimes people that go out camping and hiking, that we don't see very often, but occasionally we'll see Lyme disease, which will give us conduction abnormalities, and it's treatable without pacing. And we see sometimes in inherited cardiomyopathies like Lamin cardiomyopathy, abnormalities of the conduction system. The PET scan and the MRI scan, we wanted especially to exclude things like sarcoidosis of the heart, active sarcoidosis. The bloods, all electrolytes were normal. The thyroid functions were normal. Lyme serology, as I said, were normal. So everything, we didn't look at the coronaries. There was no troponin rise. There was no history of angina, and his resting ECG, as you guys saw, was completely normal. And equally, when he had these episodes of arrhythmia, when we looked at a 12 lead on the telemetry, there were no signs of ischemia. So if I go back to the question that I asked, would you put a temporary pacing wire in? So I can understand the people that said, yes, I would. We didn't put a temporary pacing wire in because these episodes were transient, very, very transient, as I showed you at the beginning, that they were happening for about 20 to 25 seconds at a time. And in order for us to do the investigations, especially the urgent cardiac MRI. We wouldn't be able to do that with a temporary pacing wire in situ. So we didn't put a temporary pacing wire. So the answer that we felt, well, this is what we did. We didn't put a temporary pacing wire in. We had him on IV fluids to normal saline and Hartmann solution, because as I showed you that the sinus node slowed considerably before the AV block happened. So the only real condition that will give you slowing of the sinus node and slowing of the AV node and the conduction system is vasovagal, is vagal inhibition. So if I show you here, this is an asystolic, atypical vasovagal syncope. It's predominantly a cardioinhibitory response. We don't know why in this man it suddenly happened at this time. It may be that he wasn't preconditioned for exercise for a couple of weeks, and suddenly he went out and did exercise and became prone at that stage. We don't know. And a lot of these atypical vasovagal syndromes, we don't know why they suddenly happen. People manifest them without a cardioinhibitory responses, without reduction in blood pressure. They happen as a secondary feature. In his case, it was very profound. He had limited or no prodrome. He had frequent recurrences in that 48-hour period. After that, when we had his IV fluids up, we gave him, in order to take him for the cardiac MRI, and I was actually sat there supervising him while he was having the 45-minute cardiac MRI, we gave him infusion of isoprenaline or isoproterenol to get his heart rate up, maximize the effect that his heart rate and conduction will continue. Reassurance, a lot of reassurance, IV fluids, boluses, and then running at 100 mils an hour. And after 48 hours, whilst in the hospital, he didn't have any more recurrences. Now, another question that I have, and I will ask this question and go back to the slide, is would you put a permanent pacemaker in this man? So we've established that the diagnosis is an atypical asystolic vasovagal syncope. Would you put a permanent pacemaker in this man? And again, I would appreciate if Dr. Fateh could open the poll. And yes, no, don't know. So, right. So the summary of the survey is coming out that 60% of people will put a permanent pacemaker in. The remaining 30% are split between no and don't know. And I'll tell you what we did. I put a permanent pacemaker in this man. And the reason being is that if I were to follow current guidance, be that from the AHA, the Heart Rhythm Society, or the European Society of Cardiology guidance, it indicates that if you have someone who is above the age of 40, who has had vasovagal syncope with predominant cardioinhibitory response, or has had vasovagal syncope with, or even asymptomatic pauses of more than 6 seconds, with limited or no prodrome, then a pacemaker, there is role for pacemaker implantation. I couldn't say it's a recommendation, but certainly there is role for pacemaker implantation. And that guidance is based on issue 3, which is the third international study on on cardiac syncope of uncertain origin, and that is a study that originally was published back in 2012, where they looked at, it was a randomized control study and it was double-blinded, and they looked at 511 patients who were over the age of 40, who had recurrent vasovagal syncope or reflex syncope, and 17% of these had documented asystole, and either with missed pauses of more than 6 seconds, with or without syncope. And they took these patients and they randomized them into 2 groups. One group where they gave them a dual chamber pacemaker with a rate drop response, so the ability to detect when the sinus rate is slowing in order to kick in with DDD pacing from the atrium initially to try to prevent syncope from happening, to render them pre-syncopal. And the other group, they put the pacemaker in, but they actually programmed it so it was off. It was only sensing. And they followed these patients, and they followed them for about 2 years, and then they went back and reported, and they found that that in a majority of people, 57% that were in the SYN group, they had recurrent syncope. Well, the pacemaker was turned off. And then they found that 25% that had their pacemaker in and on, programmed to DDD pacing, also had syncope. So although there is guidance to kind of to support putting in a pacemaker in, we really don't know whether that's the best thing to do. We know in a cohort of patients, especially if they're older, you may render them, instead of fainting completely, you may render them pre-syncopal enough for them to be able to abort their episode, or lie down or something, or sit down, or do ergometric exercises to boost their blood pressure and just prevent them from completely blacking out. Or the pacemaker will kick in, and before they lose consciousness, they will actually be able to continue doing what they're doing. So there is a quarter of those patients, despite them having a pacemaker, they continue to have blackouts. So there is guidance. We put a pacemaker in because, well, there was nothing else we could do. He did have prolonged ventricular standstill. We put a pacemaker in which had the ability to detect rate drop. So in order to try to minimize the episodes, we talked to him extensively about lifestyle modifications, things like enhancing his hydration, putting salt on his diet, ensuring that, especially if he were exercising or if he were ill or had fever, that he supplements his fluid balances. And despite us putting a pacemaker in, probably 4 weeks down the line, he presented again with syncope, and the pacemaker functioned normally. It was pacing, but despite that, he had syncope. So it is one of those very difficult clinical scenarios. So if there are any questions, I'm happy to take any questions. You can type them in as we go along. I wanted to mirror this case that I presented of the 49-year-old man with a case with very similar clinical features, but very different prognosis and very different mechanism of underlying conduction problem. And this is case number 2. It's a 71-year-old man, so older than the other man. He is of normal build, and he's a chap who sustained an inferior myocardial infarction about 10, 11 years ago, 1996, so that's almost 19 years ago. And at the time, he had revascularization with medical therapy, so only streptokinase, and he made a good recovery. He was early streptokinase, no intervention in those years. He didn't require the balloon angioplasty was being done at the time, but he made a good recovery. And he continued to have good LV function. His EF was in the region of 55 to 60%, and he did very well for many, many years. And he represented to the electrophysiology clinic with 3 episodes of syncope that happened in the last 12 months. And these episodes are far and few. There's no particular trigger to the events. And in the investigation, an echocardiogram confirmed that he had good LV function. His resting ECG was fine. And he had external loop recorder fitted, and it showed asymptomatic 6 beats of a broad complex tachycardia on the external loop, and it is thought to be a non-sustained VT. And he was medicated on very small dose of beta blocker and ACE inhibitors as secondary preventative therapy status post myocardial infarction. So given the fact that he's had these 3 episodes, we were not entirely sure whether his syncope was related to a ventricular tachycardia or what the underlying cause was, especially that the external loop recorder, when documenting the broad complex tachyarrhythmia, he was asymptomatic at the time. So given the infrequent nature of the syncopal episodes, I elected to put in an ILR. And this you see at the screen here, the ILR, which is the old Reveal device, implantable loop recorder that just goes subcutaneously, and it allows us the ability to, it will automatically record any slow heart rates below a pre-programmed figure, which usually we would put kind of below 40 beats a minute or so, and it will detect fast heartbeats above a pre-programmed figure, which we would normally put along the lines of 170 beats a minute or something like that. And it also has the ability it has a little remote control that the patient carries with them, and if they do have a similar episode to their clinical symptom, which is whether palpitations in cases of people with palpitations, or syncope in cases of people who have syncope. And sometimes if they black out, their family member, whoever's with them, can just put the little remote control over the device and press it, and it will record up to 15 seconds prior. Equally, if it was a rhythm that happened within the parameters that have been set, it will automatically record. So that's the background. So this screen here is an episode. It's called a dot plot. I will mention that this man lived very far from the hospital, and it was a long trip to the hospital. So we provided him with a care link, which is the ability to transmit remotely using a telephone line. So a kit, they plug it into the wall for the telephone line, in this case because it's a Medtronic device, and they can transmit to the hospital for us to see what's going on. So we had a CareLink transmission. It was an automatic CareLink transmission. We asked them to kind of attach their CareLink every day at a certain time when they go to bed, or a certain fixed time of the day. We asked them to attach their CareLink. And so we had a CareLink transmission come up, and it was flagging red on our screens. And so when we open the CareLink transmission, we find this. This is an episode that's happened. On the x-axis here is the time. On the y-axis here is the cycle length in milliseconds rather than in beats per minute. And then we have, this is the ID of the episode. It's the 27th episode. And the device will tell you what it thinks it is. It thinks it's asystole. It will give you the time, and it thinks it was asystole for 3 seconds. That's not necessarily always true. But this, yes, so Dr. Khalid Slake is making a comment that injectable loop recorders, that is true. There are these days injectable loop recorders from Medtronic that don't require a little incision. They are probably a quarter of this size, and they have the same technology. However, they're probably double the expense, if not more. So some areas have them and some areas don't, and some areas will reserve those only kind of for the younger people, the teenagers, the women who are worried about aesthetics. But in someone who's 71, we would usually give them something like this. So this screen here, it shows you the average heart rate in beats per minute in milliseconds. So we can see on this dot plot, you have one type of dot because it's not a device with electrodes in the heart. You only have an electrogram that it reads from the ventricular beat. So we see these, every little dot is a ventricular complex, and we see he's going around between 50 to 65 beats a minute. And you can appreciate that this is happening almost almost 2 o'clock in the morning. So this is not a transmitted symptomatic episode. This is an episode which was automatically sent over. And this is, so in the night, you get variabilities of the heart rate because when we're asleep, our hearts don't have to work as fast as we need them to do when we're awake. And so we get a little bit of sinus arrhythmia, a bit of vagal tone happening. And then we go along and we have a sudden slowing of the heartbeat here. And you see then there's another 2 beats that are happening. So these beats are also slow. And then after a few seconds, we have return to baseline. So we want to see what that is. We can make a differential diagnosis based on that, but we want to see what that is. So to progress, this is the electrogram that we printed out from the episode. And you can see on the top screen, so there are 2 kind of rectangles. On the top hand screen, you can appreciate that there's a kind of a sharp, so I'm going to use my pencil again. So there's a sharp here. These sharp deflections, which are positive, these sharp deflections, and here we see the cycle length, and the cycle length is probably in the region of 900 milliseconds. So these sharp deflections represent the ventricular electrogram or the ventricular egram. And we see these, and they're carrying on. They're relatively stable, ranging from 880 to 930. So a little bit of variability relating to the slowness of the heart at night and the vagal tone. So 66 beats a minute or so on average. But then, if you can appreciate in the bottom screen, we lose completely that ventricular electrogram, or that electrogram that we're seeing, that it says V-sense here. So you see this here, that says V-sense, and that V-sense is a sensed spontaneous ventricular episode. But then I want to draw your attention to here, to these little ones here, and I will show you those in the next slide. So if we come down, we see that those are happening at a regular interval. The device, the reveal, is not detecting these, it's not recording these. And then it puts out, there's this beat here which has a different morphology to this one. The polarity is negative, these are positive, and it's happening a little bit early, so this is of different origin. So if we're saying that these are sinus beats that are happening, this is probably an ectopic beat coming from below the AV node, so ventricular ectopic, and then we have, it continues on. So if I were to progress, and I show you here these little dimples or little inverted are P waves. The P waves in this slide is very nice. We don't usually see them, but this is very nice. We see the P wave just before the QRS, the P just before the QRS, and these little dimples are happening before every QRS, so these are sinus P waves. And we see, despite this loss of the ventricular beat or the ventricular egram, we still have these little dimples, and they're happening at regular intervals, and these regular intervals do not change. So there's no slowing of the sinus node here, and we see here that this ventricular ectopic comes in, and even though it comes in, it's not interrupting the sinus node going through. So if we carry on, so I wanted to ask, what do you think, and I don't think I put this in the poll, but what do you, the differentials that may come up in this type of situation are, is this high nocturnal vagal tone? Is this paroxysmal AV block? Is this obstructive sleep apnea? We see in obstructive sleep apnea varying degrees of sinus node disease manifestations with sinus slowing, sinus pauses, and various AV node blocks, or is it none of the above? And because, so if anyone, feel free to kind of write what they think it is. I don't think I put this in the poll for the interest of time, but did we put it in the poll, Dr. Fateh? I can't remember. Yeah, so in the interest of time, we didn't put this in the poll. So you can vote on what you think it may be. So these are all differential diagnoses that need to be going through your head when you see something like this. Remember, this happened at 2 o'clock in the morning. He was asymptomatic at the time. But there are pointers that I want you to really look out for if you ever have a case like this, okay? So if I go back just to show you that the sinus beat here, following the QRSs, and if it come down below, the sinus rate is absolutely the same as it was up here. There's no slowing of the sinus node. The sinus rate is not being modified by the presence of the ventricular ectopic. So the sinus node is doing what it wants to do. It's not interested in what's happening below the AV node. There's a P wave in here. So here there should be a little arrow that I should have put. So all these are exactly the same. And then suddenly the conduction comes back. So you have this ventricular ectopic escape beat, a few beats of non-conducted, and then suddenly conduction comes back. So we have 1, 2 beats non-conducted and conduction comes back. And I want you to pay very good attention to this, because this is not something that we see very often, and it recurred on another trace. So if you look here, that these P waves that are happening here, and these P waves are not affected by what happens below the AV node. And this, if you have a look here, this is happening at night. He's asleep, and this is 6 seconds here, second here, and probably 2 seconds here. So he's having this heart block for about 8 to 9 seconds. Okay, so this here, I brought it up because the mechanism is completely different from high vagal tone, and it is not obstructive sleep apnea. This is something called paroxysmal AV block, and it's very important for one to recognize this, because here this is a disease of the His-Purkinje system, infranodal His-Purkinje system, where there is the His-Purkinje system, the escape rhythm is unpredictable and can be you can't rely on it. So in these people, even though he's asymptomatic, he's at night. Yes, he's had 2 syncopal episodes in the past, but this sudden change of normal conduction to complete AV block happens because that escape beat, or that PVC, and it could happen with a PAC, with a His extrasystole. These result in concealed conduction into the AV node, and they cause the AV block to happen, and the conduction resumes incidentally when another beat comes in. And it's important to recognize this, because these are one of the conditions that cause people to die in their sleep suddenly. And this bottom rectangle here, if I show you, these are a bit squashed. It's because of the way I had to crop the picture. So these beats are exactly the same as these, but they're a bit squashed in order to fit them in on the slide. But you can see there is a junctional escape probably that's come in here, and it's initiated conduction again. And paroxysmal AV block, precise mechanism we don't know really. It's still speculation. A lot of theory goes into it. Hein Wellens is one of the top people that talks about this, and it's always infranodal. It occurs because you have lengthening in a critical interval, be that in the PP interval or in the His to His interval. And if we were to take this person into the cath lab and probably initiate into the EP lab and put in extra beats from the atrium or from the junction, from the His, we could probably see that this person develops infrahissium block. Usually the ECGs are normal outside of the episodes, and it's dangerous because of unreliable escape mechanisms, and it's thought to be related to phase 4 block of the action potential. So the depolarization in the automatic cells, which are the pacemaker cells in the heart, if someone has a diseased conduction system, they can get phase 4 block when concealed retrograde conduction happens because of so I have a question here. How would obstructive sleep apnea look like here. So obstructive sleep apnea, usually it wouldn't be related to a critical interval like occurrence of a PAC or a PVC, which initiates a conduction abnormality and allows resumption of a conduction abnormality. Obstructive sleep apnea, you'll have features of obesity hypoventilation syndrome, or someone who has, you have the history that the person is snoring, or they're apneic and they stop breathing in the night. And a lot of the clinical features will help you differentiate. With obstructive sleep apnea, we don't usually see disease in the His-Purkinje system unless these people also have advanced conduction disease. So this is a kind of just a reference to put in. This was originated back in 1973, where you can see here equally there's a PAC that comes in, shortening of the sinus, the shortening of the P to P interval, and then you have 2 beats which are completely blocked. And this is the proposed hypothesis behind that you have phase 4 block, and which will lead to that happening. So, any questions? Any questions? So, I'm conscious of the time restraints. I wanted to show you this. This is something that you probably won't see every day. It's the only case that I've seen of this nature in 15 years of practice, and it's a 60-year-old lady. So this is case number 3, my last case, and it's a 60-year-old lady, very fit 60-year-old lady, works as a teacher, and she presented acutely with near syncope in the supermarket, shopping, and suddenly she almost fainted, and the supermarket staff were a bit worried, and they called the ambulance and sent her to the hospital. And on questioning, she had a 2-year history given a diagnosis of asthma with progressive exertional breathlessness. And she's using her Ventolin inhalers repeatedly to try to relieve this breathlessness. There's no history of wheeze or cough, but she's had 2 episodes of near syncope within a week. Never actually blacked out. And I was shocked to see that she'd never blacked out when I found out what I found out. And I will show you the pictures. So looking at the ECG, the ECGs, we see that a clinical examination really didn't show anything, apart from an elevated JVP, intermittently, I should say, and sinus tachycardia. So looking at the ECG, we see it's a tachycardia, and we see that the P wave polarity is going from high to low. It's prominent, so we've got P pulmonale. The tachycardia rate is about 120 beats per minute, so high to low, so it's originating in the sinus node, and it's posterior to anterior, so negative in V1. And we see that the P is very, very large, abnormally large. The P wave is even bigger than the QRS complexes in the right precordial leads. And we also see the feature here of the Q wave in lead 3, T wave inverted in lead 3, and we see the S wave in lead 1. So one starts to think about, oh, what could be the differential diagnosis of this? And I'd like, before I say too much, I'd like you to vote on if you could choose one investigation to do. So in terms of her clinical examination, she was not hypoxic, she was tachycardiac, JVP was intermittently elevated, it wasn't elevated all the time. She looked rather well, I must admit, when you see her at the end of the bed. And she wasn't panting, she wasn't tachypneic, and if you do one investigation, obviously some people have the ability to do all the investigations, but if you could choose one investigation that would give you the most information, which one do you think you'd choose? So I'll open up the poll for voting, or I'll ask Dr. Fateh to please open up the poll for voting. So what investigation would you do next if you could choose one? So you're in a kind of MCQ type exams, and it's saying which is the most valuable investigation you would do. So I have a couple of responses on the chat room, which I agree with. Okay, I think I'm coming up to time. People are making me aware of a little bell. So are we finished with the polling? Okay, so a couple of more seconds. And once we finish the survey, I will send you back and to have another look at the ECG. It's not a common cause of syncope, I must admit. I have to throw that in there because it's something that you probably will see once in your life. Okay, so various responses, majority of which say echocardiogram, and yes, I agree with those who responded with echocardiogram. So if I could choose one test that I could do, I would do an echocardiogram. Doing an ABG is very non-specific. It may show you that the person is hypoxic, it may not. She was not hypoxic on air, believe it or not. A chest X-ray may or may not give you any information. So this is going back to the ECG, and this is a brilliant ECG. So looking at this, you know, one would wonder, could this be a large pulmonary embolus? Could this be pericardial effusion with features of tamponade? Well, I don't think it would be pericardial effusion with features of tamponade because we don't see that the alternates, the very small complexes and the alternates that we would see in pericardial effusion. We're seeing something with a very large P wave, something with high pressures in the right side of the heart. The P wave origin is still from the sinus node, so this is a sinus tachycardia, but the P wave in the right precordial leads, V1 up to V3, going from the right side, kind of across the septum, is the P waves are outscore or outscale the QRS complexes. So I'm going to show you, I've got one kind of still image to show you about what this was, and I want people to text in or write in what they think this is. So this is like a shocking thing when you put the probe on, and I just want people to write in what you think it is. And I want you to look at where it is, what it's attached to, the morphology of the mass in question. Is it homogeneous? Is it not? And it's like a pear in the right side of the heart. Okay, so I have a few people saying blood clot versus myxoma. Okay, so in this case, I can tell you that from the other images that the IVC is clear, so it's nothing coming up from the IVC and invading the heart. Okay. Yes, a cardiothoracic surgeon here is saying angiosarcoma. Have you seen one of those? So it is a very unusual mass, and it will be the cardiothoracic surgeons who see this because they're the ones that take it out. Us as cardiologists, we don't see it that often. So this is actually, it was actually a myxoma. Okay, and this is the first and only right-sided myxoma that I've seen. I've seen left-sided myxomas. I've seen familial Carney's complex, and even the myxomas that I have seen are probably maybe the beginning of double digits, so something about 10 to 12. Yes, I am an electrophysiologist. I still do echo, I still do TOE, but I probably don't see as much as the people in the echo lab who are doing echoes all the time, but this was the size of this, and this history of asthma, the 2-year history of asthma is probably all related to this mass and the growth of this mass over the 2-year period. And her near syncope, we can easily identify now why. I was surprised that she didn't have full syncope with it occluding her tricuspid valve, and it's because she's a very fit 60-year-old lady otherwise, but that is all because of loss of preload to the left side of the heart, and the breathlessness is related to the fact that she is having very low venous return to the pulmonary circulation into the lungs. So yes, and I would ask the cardiothoracics in the room, how many of these have you seen? Because they're the people that you know, see them the most. They take them out, and as cardiologists, we know that primary tumors of the heart and secondary tumors of the heart are rather rare. So we do see them now and again, but I just thought I'd end with this beautiful image. And thank you for your attention, and happy to take any questions if anyone has any questions.
Dr. Nadia, thank you for this presentation. You made me very excited at the end. This is a very interesting case. I personally.
Well, I'm glad I could keep a cardiothoracic surgeon interested. EP, I know people will doze off.
I personally saw maybe 20 myxomas until now. Most of them, I would say 99. I don't remember I saw a right side myxoma. I saw left ventricular myxoma once, one out of those 20. I did 2 angiosarcomas, and one of them come from the left side, extended to the inferior hepatic artery, vein, sorry. And the second one was at the base of the left atrium. And that one I just did debulking, and I took as much of the tumor as I can. Fortunately, the lady is 73 years old, and she died after 6 months from chemo. And the presentation was very similar, but the difference was mitral valve obstruction rather than tricuspid valve obstruction, but still an inflow phenomenon. Very interesting. Let's go back to EP. I just have 2 questions, if you are okay, and we have I think we can have about 9 minutes of questioning to jump to the next presentation.
دكتور sorry على المقاطعة, لكن I think I've got people here saying, can we probably allow the questions at the end just in case we run out of time for Dr. Khalid's presentation. So I'm happy to take questions at the end. I don't want, any issues to prevent him from presenting his videos.
Perfect. Let's move on to Dr. Khalid. Dr. Khalid Slake is close to me. He is in Ohio. He's one of the cardiology interventionists in Ohio, United States of America. He will present some interesting case for us, and we will leave the discussion to the end. Dr. Khalid, تفضل.
السلام عليكم.
السلام.
تسمع فيا كويس يا محمد؟
أنا أسمع فيك كويس.
Everybody could hear me well? عليكم السلام. كويس. I'm going to actually dive into this presentation. Nadia, there was a very interesting presentation from your side. Just for a notice, when I get a consultation about syncope, I always try to avoid it, because you have a patient with syncope either have a really difficult diagnosis that will not be able to reach, or they're completely crazy. So in the interventional ward, I thought I'm going to present something very which called coronary dissection. My goals was to do a classification of the coronary dissection, classify the coronary dissection for people who doesn't do angiography and intervention. And my goal was to present 6 real-life cases, but because of the constraint of the time, we're going to limit them to 2. And through the discussion of these cases, we're going to learn certain tips and tricks how to deal with coronary dissections when they arise, and discuss a new hemodynamic support device. And when I presented my slide to Fathi and the rest of the meeting hosts, they thought this is too much to just discuss in one presentation. So we're going to do 2 parts. The first part, today we're going to discuss a quick slide discussion about the coronary dissection, show images of 2 real-time cases. And the next webinar, we're going to do the discussion about the Embella device, which is the smallest left ventricular assist device available to us to insert percutaneously, and discuss PROTECT 2 studies, which involve comparing Embella device with intra-aortic balloon pump, and see a real left vein disastrous case dissections happened in our lab. So just a few notes about complications in the cardiac cath labs. When we go in and do cardiac angiograms or cardiac catheterizations, my thought always is to prevent complications. Most of the complications in the cath lab usually relate to the actual operation. Some of them is caused by the operator. And who works in the cath lab know that just a trivial slip will lead to a disaster sometimes. Attention to details are very important in cardiac catheterization suite. The goal is to get the patients out of that lab without any complications. Everybody knows the complications related to the cardiac catheterizations are enormous. I assure you pretty much done all of these except the aortic dissections. Otherwise, the surgeon would be mad. I lost a stent in the coronaries. I lost it in the aorta. We'll have to retrieve it. I caused bleed and death to some of these people, not intentionally, obviously. There are three major things about doing cardiac catheterization intervention in the cath lab. Is you have to be prepared ahead of time. And simple things like anxiety can cause severe radial spasm to prevent you from shuffling your devices and catheter through and able to do the intervention safely or the cardiac catheterization. Hydrations, if patient is not hydrated well, they could have a significant vasal response, and you're going to spend 10-15 minutes giving them fluid and atropines and try to correct the issues. And before you go in, usually you will study the lesion very carefully, particularly if you consulted by somebody to do an intervention. All these 10 characteristics of the lesions are very important. The length, how much calcium, is it tortuous, is it bended, what's the degree of the bend, what's the status of the collaterals. And then the other things which comes with time, and the usual time, usually some people say you need at least 10 years to become familiar with how you select your equipment. So the appropriate guide catheter, and when you change it, and when you change the plan, what wire you use, the size and the length of the balloon and stent. And the commonest things in the lab is use what if scenario. And what if scenario is basically, if I balloon these lesions, am I prepared to do the next step, which is stenting? Maybe you cannot stent. If I deploy the stent, will the perforations happen after that, and what's my next step? So what if scenario is very important happening in the cath lab. And the execution is crucial, where you have only one hole to enter either the radial or the femoral. But this hole is very important because you could do marvelous complex angioplasty and then patient die from significant retroperitoneal bleed because your stick is a little bit high, or they end up with a massive pseudoaneurysm because your stick is very low. And I've seen cases where you could dissect the subclavian arteries and patients lose their right arm. And so as a rule, if you work in the cath lab, never pull, push, inflate, or deflate without looking. This is one of the basic rules. And if you are somebody who works in the cath lab and do interventions, take a second and think of your hands. If you're a gentle instrumental man, if you touch those catheters in a gentle way, in a soft way, that means you're not aggressive with this equipment. If you're holding this equipment very tight, you know that you need to change course. And lastly, in the cath labs, we usually ask for help. I see people who work with me who have 30 years of experience, they still ask for help. So if you're stuck, ask for help. 30% of all conventional balloon angioplasties associated with significant angiographic coronary artery dissection. And some people actually necessarily not consider the dissection as a complication because the mechanism of lumen enlargement by the angioplasty balloon involve the stretching of the vessels and cracking of the plaque, and this is usually manifest as a dissection. And apparently, a lot of intimal tear after the balloon angioplasty we really don't see angiographically because it's not very obvious. This is an example of a case, still pictures of a patient I did a week ago. He's 64 years old who had bypass surgery at a young age. His cardiac catheterization showed all his grafts are open. Lima to the LED was open, the vein graft to the circ and the vein graft to the right were open. But clearly he had a very tight circumflex acute marginal lesion. I don't see the pointer. Let's see if I could get the pointer up there. You could see that there's a lesion here where the wires crossed, very tight lesion, almost 99% narrowing. And the pictures below it show that we ballooned this lesion and we convert the lesions from a very tight lesion to a dissected lesion. So you see there's a flab of plaque parallel to the lumen of the vessel itself. And the pictures on the left lower corner show that we sealed the dissections with a stent. He did very well, but this is a good example of how we dissect the vessel. With the drilling device we use, like a rotoplator or laser angioplasty or high-speed rotational atherectomy, we see more dissections. In the old era, if you are an old interventionist, remember when you inflated that balloon for 10-15 minutes, the incidence of dissections pre-stent era was very high, almost like 11%. This incidence of dissections reduced dramatically once the stents being invented and we start using them more. And in this current era now, the biggest fear always, if you deploy your stent, are your stent edges are good or not, particularly the distal portion of the stent, because most of people who go back to the cath labs, because of the inflation of the stent, edge dissection could happen, and that could be a nidus for stent thrombosis. So basically, a clot form on that dissection, close the whole stents, and you have to take the patient back to the lab. The dissection mostly we see in clinical practice these days is induced, the operator induced that as a part of the procedure. Spontaneous dissection is something happened from time to time. Throughout my practice, I think I've seen one patient when I was a cardiology fellow, postpartum patients. This spontaneous dissection was first described in 1931, very low incidence, 0.2%. The mean age people usually is 40, particularly female. Peripartum or postpartum is being described, and the LED is the most common vessels involved. You could have more than one vessel. The mechanism is you would have an intimal rupture for one reason or the other. The exact cause is not known, and then you bleed within the vessel itself and cause intramural hematoma, and then you abruptly close the vessels. People usually present with acute coronary syndrome. The patient I saw presented shortly, a few weeks after she delivered the baby, with ST segment elevation MI, and she had a stent. So commonly, you would have no cardiac risk factor for this, except peripartum or postpartum, though connective tissue disorders has been implicated for such spontaneous dissection, like Marfan syndrome, vasculitis, SLE. I've seen a Marfan syndrome had a spontaneous dissection which healed spontaneously, but the diagnosis wasn't done in retrospect. The natural history is very good if you survive the first event. So if you survive the acute event, you will do well. 10 years mortality is 7% for spontaneous dissections, and men tend to do better. 50% of people, according to this 50-year review of literatures, I see this is done by some group here, I included their names. 50% of these people will have recurrent dissection within 2 months. So these are the references regarding the spontaneous dissections. You could have that handy later on when you have access to the slide. Treatment, as I say, is really controversial. The patient I saw had a stent. Some people have been treating these people with just medical treatment, aspirin and heparin and aggressive beta blockades and statin therapy. Follow-up, nowadays I think the handy procedure used is cardiac CTA. Some people suggest stress testing, but that's an old information because of the rarity of the condition. But I think cardiac CTA will be the most appropriate test to do in these people who have a spontaneous dissection, because it could progress to a pseudoaneurysm. So to conclude about the spontaneous dissection and move on to the cases where we created the dissection. So if you have any young woman comes to the hospital with acute coronary syndrome, particularly a non-smoker with no history of hypertension or connective tissue disease, consider that, particularly postpartum. Usually the medical therapy is the most rational way of treating these people, except intervention sometimes is needed with stent, and that could be individualized. In the coronary artery era populations here, that's what we deal on a daily basis. There are certain predictors for who will have a corneal dissection or not. So if you have an eccentric lesion and you balloon it, it's likely you're going to have a tear. If you have a long lesions, if the vessel is tortuous, anything type B or C usually dissect, and left main is very important segment. Sometimes they dissect even if you don't have a disease. Other predictor is if you have used certain guiding catheters. So the shape of the guiding catheter itself, for example, implants could poke into the ostium, either the superior or the inferior portion of the vessel, and can initiate a dissection flap. If you are a vigorous catheter manipulator in the cath lab, you could deep throat the catheter and you create a dissection. And if you are injecting the contrast vigorously, you could initiate dissection which spread down to the vessel. So if I'm going to actually ask you to take one message from this whole presentation, is to know the classification of the dissection, how we classify dissection, and we classify them to group A, B, C, D, E, and F. So if you have a dissection A or B, these are the benign form. So you have a very minor radiolucency area seen where the lesion is, and there is no staining left behind, and usually the stain will disappear. This is type A or B. B usually is a bigger dissection, but it's parallel to the wall, and this radiolucency only seen during the injection. Now, once you have a dissection C, D, and E, F, these are the dangerous ones. These are the ones which progress. The dissection C, when you have staining hanging beyond the plaque or the lesion. So the staining will stay after the contrast is cleared, and usually outside the vessel. This is called type C. Type D is the barbershop hole. Basically, you have two lumen, a false lumen or true lumen, and there are different contrast staining within the vessel. This is one of the dangerous form of the dissection. Dissection E is basically persistent stain within the lesion itself. The dye will stay persistently for a few seconds after the contrast cleared through the vessel. And the worst one is a dissection type F, where you have complete occlusion of the vessels. So without overdue, we're going to go to the first case here. So we keep those classification in your mind. A, B is the benign. C, D, E, F are the malignant one. This is case number 1. This is an acute ST segment elevation MI. A patient I did myself early one of the morning of Saturdays. Big time smoker. She smoked for more than 40 years. She had long-standing history of hypertension. She comes to the emergency department with severe sudden onset chest discomfort, and her EKG showed the elevation in 2, 3, and AVF. And Fathi, if you hear me, you could show the audience the first video. So we'll give it a few seconds here. So this is not the first picture though. We'll wait for the first picture. So this patient was taken urgently to the cardiac cath lab for cornea angiography. She received aspirin, 4,000 units of heparin, and she got prolentalode, 180 milligrams of prolentalode. This is our protocol to expedite their transfer to the cath lab. So we entered through the radial approach. And this is her first picture. So what we'll do, basically, I took the patient to the cath lab. This is a Judkin right catheter. You can see this is the injection of the right coronary arteries. The right coronary artery is a very small vessel. It's diffusely diseased, but there is complete occlusion of the distal right coronary arteries, and you can see there's a clot within the vessel itself. And you could tell that by the remaining of the staining beyond after the dye clears. So it's clearly she had 100% occlusion of the distal right coronary arteries, which is consistent with the EKG findings. So if we go to the next video, Fathi. I'm afraid to touch the videos from my side, so it will disappear like the last time. So usually what I do from the radial approach is to go with the 5-French Judkin right, because it's easy to maneuver any tortuosity from the arm. And this is the Jetcon left 3.5 showed that the left coronary circulation in general has no obstructive disease, very mild disease in the circumflex, proximal portion, maybe 20-30%. LED shows diffuse laminar irregularity, but there is no obstructive coronary artery disease. So after we take 1 or 2 pictures of the left side, we go back and intervene on the distal right coronary artery. So this is a high torque flabby wire. You could see the catheter is a guiding catheter now, Jetcon right. We crossed the lesion easily with a high torque flabby wire. You can see there is a subtotal occluded lesion there, but we crossed nicely. The flow is much better. The wires in the PDA, there's a moderately sized posterolateral branch. So just crossing it without an export catheter extraction thrombectomy, because I thought the vessel is very small and it's a long way to go down. So I decided to balloon this lesion with a small balloon, 2.0 by 12, just a simple balloon. So if we go to the next video, Fatih, and you could see that the balloon, I withdrew it to the back of the middle of the vessels, but you can see there is a dissections after we ballooned that. And this is balloon created dissections is a type B. It's not flow limiting. The dye doesn't hang there. So that's usually happen when we balloon with the stent. It still look hazy. So I decided to take the balloon out and put a stent in. And you could see that the next video, that's the stent. So the stent looks beautiful. I aim to position the stent just right where the bifurcation is. I use a 2.25 by 14 resolute medicated stent. You could tell the patient's EKG is improved, her chest pain just went away, and she's doing very well. And this is where the scenarios in the cath lab usually happen is, what if I do more, or if it says factory to stop right here. And if you actually look at these pictures and the patient conditions, you could argue that you did a great job, you fix the culprit lesions, get your equipment out and leave. But the next video will see that when I took pictures of these vessels from the REO and AP cranial view, it appears that that guiding catheter did something to the proximal part of the vessels. There is like a little bit of haziness there. So I say this doesn't look good, but particularly from the REO view, and the guide maybe just caused some intimal tear in the proximal portion. So I decided to go ahead and put a stent in the proximal portion of the right coronary arteries. And you can see the next picture that we put a 3.0 by 18 resolute in the proximal portion. And the thinking at that time is if she had an intimal tear in the proximal portion, sending back to the cath lab, she will definitely close that back again and she will come back with another acute MI. So you lose all your work. So this is pictures of the stent inflated in the right coronary arteries. And in the next pictures, you will see that she got an excellent result where the proximal portion looks nice. And knowing that this vessel is diffusing disease. Now, when I took these pictures, I didn't like the distal edge of the stent. So I took more images from the REO view. So multiple views will always help you when you do interventions. You want to know how does it look like from different views. And the way I was thinking, if we're going to stent more, we're going to stent the whole vessel. So we're going to end up with middle jacket, the whole vessel from the proximal to the distal. So I was hoping that we'll get away from bullet and stents. So this picture is actually taken after we removed all the equipment. So I took the wire back, and then we took all the equipment back out of the patients. We even removed the radial sheet out. We put a band on, the R band. And then 10 minutes later, we moved the patient to the table, off the table, and she was going to the CC when she started having recurrent chest pain. So we put her back on the monitor, and clearly she had severe ischial segment elevation, MI clearly seen from the monitor. So we have something happen to that stent, and this is what happened. You can see the picture here. There's a complete occlusion of the distal portion of the stent, and the right coronary artery is all gone. You can see the stent at the bottom there. So we basically converted gave her type B dissection distally, which we sealed with the stent, but we gave her type F dissection, where it's complete occlusion of the stent. And it's clearly there's some form of dissections happen beyond the stent, especially with the peak looking stent like this. When you have a peak looking like that, that's probably a dissection. So we put it back on the table, and then I went back from the groin and then passed the wire easily, I must say. The wire crossed really easy with no difficulty. So I was hoping that I am within the lumen of these vessels. And then I ballooned where the edge of the stent is. You can see the balloons going up there. And you can see the patient's arm. She's complaining of chest pain. She's holding her chest while we're going up with the balloon. Now, she is hemodynamically stable. She had normal blood pressure, but she was in pain. And as we try to open this, we balloon it more. And you will see what the next picture is after we balloon. So the picture after we balloon is there is no flow in the right coronary artery whatsoever. So this is what I'm talking about in the cath lab. A 10-minute case could convert to be a 4 hours case. And this is what happened in this patient. So I will spend the next 3 hours trying to open this vessel. So at this moment, when there is no flow in the right coronary arteries, I wasn't sure if I'm still in the lumen or not. And this is a flow limiting. Is it no flow? Is it distal embolization? But I could see there is a side branch coming off that middle segment of the right coronary artery. So I decided to IVUS, and I did intravascular IVUS, which clearly showed that this wire was not intraluminal, was an extraluminal wire. And in retrospect, I was ballooning actually to a false lumen, and that's why I'm not getting any flow. So because of the intravascular ultrasound finding, I decided to bring another wire in and try to go intraluminar. And Fatih, if you go to the next pictures here, you can see I'm bringing another wire up there. There's some staining distally, so there's some contrast going to the distal vessels. I'm keeping my first wire as an anchor so I don't lose the position of the guide. And if you go to the next video, you will see that I was able to direct this wire to a different direction, to a different branch, and likely the posterolateral branch. So I'm having this anatomy pictures from the previous lesson. I'm trying to work with it. So this wire definitely is in a different direction, but I'm not sure still if I'm still intraluminar or extraluminar. It's hard to tell. So one of the tricks we use in interventions, even in the presence of intravascular ultrasound, is to introduce a little over the balloon, little balloon distally, and then inject a little dye through the balloon, and that will tell you whether you're intraluminar or not. And I'm not sure whether we have this picture or not, but you could move to the next video, Fatih. And this is the balloon, and injecting a little contrast to the balloon, and you can see there's a dye in the distal vessels, and this is reassured me that I am actually intraluminar in the second wire. So because of this, I decided to stent the whole vessels now. So I start the stenting from where the bifurcation is, going back all the way, reconstructing the whole vessels. So next picture, Fatih. So this is one of the tricks if you don't have intravascular ultrasound. Put a distal balloon, inject little dye, and see whether you're in the vessel or not. And clearly now we have a flow back after we use I use a 3/0 by 38 medicated stent from the distal portion to the mid segment. So this lady had type B dissection distally created with the first lesion. Then I gave her type F dissection second, and then the pictures before that, if you go back to the previous video, Fathi, that'll be very helpful. So the middle portion, you can see there's a spiral dissection. You see that spiral direction, there's two lumen here. The first portion of the vessel has dark dye, and then in the middle portion, there's a dissection flab. So she got the three forms of dissections, basically B, F, and D. So because it's still like that, I stented the rest of the vessels, and the next picture will show that the vessels actually was wide open. But I end up stenting the whole vessel at the end. And we got a Timmy-tree flow. The vessel distally is mildly diffusely diseased, so I didn't do anything about it. It's already 3 hours from the beginning of the second procedures, and we give it a lot of dye, and patient is tired. So we decided this is a very good result. I think this is the last video for the first case. The second case is let's see. Let me go down here. Second case is, we call it case C, I believe. All right, so this is an example of type C dissection. 65 years old female, history of hypertension, diabetes, classic story. It's a segment elevation MI. Let's go to the angiogram, Fathi. And she goes to the cath lab. We do cornea angiography. She had an acute inferior myocardial infarction. I think Fathi is going to need some time to load these pictures. So we'll give him a minute or so just to load the first picture. So 95% of cases we do from the radial approach in our cath lab. This is her left circulations. Her left system looks completely normal. So I have only one picture of it, so we go to the right coronary arteries. And the interesting part of the right coronary artery is the presentation. This patient has what we call type C dissection, where the ST segment elevation to rupture plaque, and this rupture plaque created and initiated the dissection. So if we go to the next angio, that's how. So we'll give them a few seconds here to load the second pictures. So to answer some of the question, obviously the first patient survived the event. She did very well, actually. And she went home. This is the pictures of the second patient who presented with this, the second elevation MI. And as you notice, this is an angiogram. There's a dye stain hanging in the proximal portion. And this is a plaque rupture and dissected throughout the whole vessel. And you could see that there is intraluminal hematoma extending all the way down just prior to the bifurcation of the vessels. And this is a classic angiographic features of type C dissection. The challenges for the interventional cardiologist here is to confirm that they cross these lesions within the intraluminal portion. You don't want to go knocking around the wire in the dissections and really make things worse. And I think hydrochloride oil was used to cross this lesion. And then an intravascular ultrasound was performed to confirm the positions of the wire. And if we could move to the next picture, Fathi. This is an aerial view of the same dissected plaque. You can see the dye staining just behind. There's Timmy-tree flow in these vessels, and eventually we'll see that this lesion was stented, and the vessel was stented from the tip to the proximal portion. And you see the operators started with ballooning distally, and he will end up with a little jacket too. Now, most of the complicated cases like this, particularly with multiple stents, usually start 2B3 inhibitors. This is the final result. And you could see that he lost the side branches. And one of the scenario is the wire itself may go within the lumen and then extraluminar, and then it comes back interluminar. And that's why when you stent the whole vessel, you will lose the side branches. So it's even with the intravascular ultrasound, sometimes it's really hard to confirm the positions throughout the whole course of the vessels. But the patient had TIMI3 flow. This patient had a no flow, and then we treated them with nibride and nitro and adenosine and all that stuff, and it's improved the flow at the end, and she did very well. So the last case I'm going to present, if we go to the presentation, is, well, actually, maybe Fethi, just go straight to the pictures, and because I know the history of this patient. The last one is pure angiogram. So this is a fellow who's doing an angiogram. This is, I think, 74 years old female patient who had history of angioplasty of the diagonal and the LED. And she came into the hospital with chest pain. And she was admitted. Her EKG is not specific. Her enzymes are negative. She was admitted to the hospital overnight and scheduled for cardiac catheterization the next morning. This is the angiograms. And you could tell this is done from the radial approach. And this is the right coronary artery angiography. You can see there is a moderate lesion in the proximal to the mid segment of the right coronary artery. She had prior stent to the distal RCA2, which was patent. And this is a Judkin right 4 catheter. Then we use a Judkin left 4 to the left side. And if you hold this angiogram for just a second here, Fethi, there's a very important angiographic features we always pay attention to. So I personally use 3.5 Judkin left. And if you can let it play and just rewind, that'll be great. But just keep it this angiogram as is. You can see that the stent in the diagonal is open. And she had a stent in the LED. There's minor in-stent stenosis. But look at the tip of that catheter. It's poking into the left main. It's pinching it. It's stenting in the left main. And this is one of the angiographic features you have to be aware of if you're an angiographer. Always the tip of the catheter should be parallel to the lumen of the vessels. And I rarely inject any angiogram unless I see a parallel, but this one is not really parallel. So let's look to the next angiogram, and you could confirm that that tip of the catheter itself is tenting the left main. And this pictures clearly showed that that tip of the Judkin left is tenting the left main. I already anxious when the catheter looks that way. But you know, the stent in the LED and diagonal looks pretty good. So what we see in the next angiogram is patient started developing chest pain. She's complaining of chest pain, and she had ST segment elevation in all leads on the monitors. And we could see that the flow in the LED, if you notice the flow, it's TIMI1 at most. So there is something happened. So the flow is not good in the LED. And if you go back and look at left main, you can see there's a filling defect right at the distal portion of the left main. So clearly that she had a dissection induced by that catheter. And this is just plain pure angiogram. There's no instrumentation, no wires or stent or balloon. So the next angiogram, we know that there's something bad happened. We go in and change this catheter to a guide. And then clearly, as fast as possible, we wire both the LED and the circumflex. And the next picture, you're going to see the clear dissections in the distal left main caused by the catheter, the Judkin left 4. So if you go to the next angiogram, Fethi, in the sequence, you will see the sections in the distal left main. So I work in two different labs, high risk lab and a low risk lab. And in a low risk lab, we usually keep at least 10 to 15 stent. We keep a couple balloons and a couple wires because this complication could happen anytime. And you can see from this angiograms, we clearly have a dissection involved, the whole left main, and the flow in the LED and the circ is not the greatest. So we were able to cross with the wire, both the circumflex and the LED. And when you have a left main, you have to wire everything possible. Whatever you have, any branches, you got to wire. And then you have to IVUS. And then the pictures which I don't have is we IVUSed both wires in the circ and the LED, and was clearly we were within the lumen. So the decision was made to stent this. In the next picture, you'll see that the stent deployed in the distal left main, extending to the proximal portion of the left main. Now, usually we have a protocol, so any complication, we keep the surgeon standby. So usually the surgeons are called by now. He knows what's going on in the cath lab. But I will say that almost always we bail ourselves with stenting. So if we go to the next angiograms, Fathi. This is the stenting of the left main. We use a 4.0 by 12 Alpine Zyme stent. And this is the post-dilatations. And we IVUS post-dilatation, we got a good result. And we were lucky to get the stent position right where the distal left main without involving the circumflex and the LED, and we got a good result with resolution of the ST segment innervation MI and the chest pain. So the next is we will see an excellent result post-stenting. And the flow is much better with some nitro, and intravascular ultrasound was repeated here, which shows complete resolution with expanded stent in the left main with nothing involved in the LED and the circumflex. And actually, we proceeded and we stented the right coronary artery shortly after this. So she had a stent in the left main and the right coronary arteries. So if there are two messages, and I think I'll conclude with this case, is cardiac catheterization. It is a common procedure, but it could turn disastrous in the cath lab. Doing a cardiac catheterization in a low-risk lab required certain preparation. And as we see that cardiac catheterization now, especially in our beloved country, Libya, is widespread everywhere in the private practice. I hope they were prepared for such cases because this is really life-threatening complications. You have to be prepared to deal with these complications. Angioplasty usually could bail you out very quickly, but you have to know what you're doing. I hope you learned about the different type of dissections and these interesting cases, and I will answer any questions.
I'll take the. Thank you very much for your presentation. Very interesting. To me, it's a lot of stenting. I get really worried when I see all of those stents. But anyway, we go back to Dr. Nadia presentation. If anybody have questions, we didn't have the chance to talk to answer all the questions for her. We'll give it about 5 minutes for Dr. Nadia and another 5 minutes for Dr. Khalid. And you can flag your hand if you need to ask questions from the smiley face on the side. I guess everybody want to do more 20 minutes, so we'll do a 10 minutes for Dr. Nadia and another 10 minutes for Dr. Khalid. Anybody have any question for Dr. Nadia Sunni? I'll start with myself, I guess. I would like to know what's her recommendation regarding his job. Does he, or the guy, especially the 49 years old, the truck driver, does he have to change his job or not? Or how would she deal with that? Number two is, for a simple cardiothoracic surgeon, I can't see always a P wave in the EKG for that 49 years old. Does he need atrioventricular pacing with the DDD mode, or just a ventricular pacing with sensing to the atrium? Dr. Nadia, you're still there?
أعطيها المايك يا محي.
I can't.
أعطي فتحي عندك من جهتك أعطيها المايك يا فتحي.
I think you have to log off for her to open. I think.
No, she has
Okay,
it now.
can you hear me? Can you hear
Yeah,
me
now I can.
Okay. So the answer to the first question, about his job. So I probably didn't make myself clear. He's a driver of a pick fork truck. So it's one of those, I don't know اللي نسموهم بالعربي اللي هي زي التراكتور لكن اللي هي تقيم الحاجات الثقيلة in a factory. Okay, in a factory. So he drives that. Now, in normal circumstances, if he was someone who had complete heart block, he would be banned from doing that vocation. But he is someone that has vasovagal singing with no particular trigger. And he did work in a place which had relatively high magnetic fields. So we did a kind of visitation to the place and ensured that that the place that he's working in, the pacemaker functioned normally in it. We didn't say that he had to change his vocation, but preferably so, because there is a potential that this may happen again, and there's a potential it may never happen again. We don't know what triggered it in the first instance. And because he was working in a confined area, and even if, you know, the machine that he works on, if he had syncope for a couple of seconds, he is not going to run into anybody. If he were a truck driver working elsewhere, or driving a high, an HGV truck, a lorry, then yes, he would be banned from carrying out his duties. Until we can, and even normal driving, we would have to ensure, in the context of repeated syncopal episodes that were unprovoked, that he would be able to, for at least 6 months or sometimes up to a year, avoid kind of having these syncopal episodes, because having a pacemaker did not rectify the symptom, basically. So that's number one. Number two, the second question about the P waves. So on his resting, we're talking about case number one, the 49-year-old, isn't it, Dr. Muhia?
Correct.
The 49-year-old, so he had on his resting ECG PQRS. So we could go back to the presentation, and I'll show you here. On the resting ECG, he has PQRS. So every P wave is followed by QRS complex. So he would be set not to pace all the time. He would be set in a DDD mode. With a rate drop response, meaning that if he suddenly started dropping his sinus rate, the pacemaker will start to pace him in AI mode until it sees blocked ventricular beats, and then it will switch to a DDD mode. and it will do that with looking at kind of 2 and then 4 consecutive PP intervals. And the rate, the pacemaker will be set at something like 60 beats a minute. So he doesn't require pacing all the time. And indeed, we don't want him to pace all the time because he has intrinsic rhythm. He only loses his intrinsic rhythm when he has these syncopal episodes. And we find, and I'm sure the audience, people in the audience that have views as well can contribute, that we find that these atypical vasovagals, or even indeed typical vasovagals, they go through clusters of symptoms. We do usually see them that something triggers them, be that emotion, be that feeling unwell, viral illness, or DNV, or something like that, or be that hormonal for females, or so we don't know exactly why they come in clusters, but they tend to come in clusters, and then for no apparent reason they improve. And they may return. He may. Some of them have 1 or 2 fainting episodes in their whole life, and it never recurs. But in this gentleman, we had a clearly documented sinus node slowing, almost like a sinus node disease, and then followed by AV node slowing and complete ventricular standstill. So. Yes, we would program him not to pace all the time. We did program him for a sensing rate response, and he did have another syncopal episode despite that, and the pacemaker functioned fine, and it did do what the rate dropped, but we mustn't forget that despite the cardioinhibitory nature of his response that we saw, a lot is also manifested by blood pressure drops. Now, in the context of the acute presentation, we didn't do the tilt test, and we didn't see, is it a mixed response cardioinhibitory along with vasodepressor? We don't know if his blood pressure first or not, but we do know that he had a profound, very quick episode. So, you know, you can only do sometimes what you can do. And we had no alternative for this young man. And in some of them, we do render them pre-syncopal. So at least they can sit down or stop what they're doing, and it avoids them blacking out completely, but they still have that dizzy spell. So does that answer the questions? Yeah. Maybe Dr. Khalid or Dr. Fathi might want to comment as well from their experience of similar episodes like this. I mean, I've seen quite a lot of vasodepressor, and I've seen a degree of kind of cardioinhibitory, and you get sinus pauses, you get missed response, but to have that profound, I mean, that is the most profound vasovagal AV block that I have seen.
Yeah, probably give the chance to Khalid if you want to comment, but meanwhile, Khalid want me to...
Yeah, go ahead, Fathi. أنت electrophysiologist.
Oh no! I mean Khalid Bouzguiya. But anyway, meanwhile,
Khalid Bouzguiya, he's an electrophysiologist too.
Yeah. So meanwhile, let me say it's a fantastic cases, Nadia. Excellent presentation. The only caveat about this case, I would say, I would have definitely done a tilt table test of this patient, just to, it may not have changed in management, but it may just prove your point that the cardioinhibitory component is much more prominent than the vasodilatory component, or vice versa. So it may help delineate the characteristics of his vasovagal syncope one way or the other. So that's one thing. The second thing, and again, I would like to hear Khalid and Yusuf. I think Yusuf Zarat also is in the audience. I would like to hear their input as well. There's a condition, not very common, it's very rare, but it may mimic this thing here. You see a young person with a narrow kind of complex, no much conduction disease here, but they may have intermittent intrahisian block, and they can mimic this. They can have, you know, I'm going to this tracing here. If you look at the rate here between this beat and this beat, it's not very much slower than his baseline heart rate. assuming they were done nearby. I agree with you. There is a slowing of the peak interval, but if you go back to his baseline, I assume his baseline heart is not very slow either. So the question is this could be, as you indicated, atypical vasovagal, etc. And I agree with the comments. We don't see much of PR prolongation. We just see sudden drop of the KRAS complexes. There may be some minuscule changes between this beat and this beat. It's hard to tell based on this, but at least here, between this beat and this beat, there's not much difference in the PR interval, at least based on the surface EKG. So one might argue that, well, could this be just intrahischium block? So definitely, I mean, again, one of the choices I would have done is probably just put a his bundle catheter, just prove that his bundle is intact and there's no intrahischium block. But again, I mean, it may not have changed the management since he got a pacemaker anyways.
Yeah. So we thought about that, but to be honest with you, because he was having these repeated episodes and because it wasn't going to change the management plan, we didn't do that. But arguably, if you put a His catheter in and you find intrahischium block, you would expect, once you put a pacemaker in, that you would expect his symptoms have resolved. So if we're saying that this is all conduction disease, his symptoms should resolve with a pacemaker. But to be honest with you, his symptoms did not resolve completely. So he had a further episode.
Right, Nadia, but we talked about before you knew that his symptoms are not resolved.
So before, so when we came to the, absolutely, so before we thought about that, and again, the tilt table test was again the issue. And this man, you know, I was called in at 10 o'clock because we put him he came over, seen him, we put him for a cardiac MRI, and the only slot that became available was 10 o'clock at night, and I was called in to supervise the cardiac MRI for this guy because we had to, obviously, we couldn't put a temporary wire in, we couldn't put any of the paddles or anything on, and if he had an episode in the MRI scanner, I was there in case he had an episode in the MRI scanner. So this was really, you know, he was having these repeated episodes. With isoprenoline, he improved in terms of his conduction. He didn't lose conduction with isoprenoline, but he became hypotensive, you know, running blood pressures around 80 and very jittery. So we were in a situation where, you know, you can't mess around and you can't kind of delay things. There was no real option to put him on a tilt test when he was having repeat. So, but equally, I think there was you were in a situation where whatever you had to do, you had to pace him. But yes, it's a valid point for the differential diagnosis. Absolutely, I totally agree. Thank you for raising that point.
Take a chance. I mean, because this is a great case, and I think it's worth people noting to think about this. Although the EKG made it so horrific, let me share with you a case that was sent to us for a second opinion only, in August, this past August. So this was a 49-year-old general surgeon, has bypassed surgery 5 days ago. He's in the ICU, he's asymptomatic, and this was his EKG. So people to look at this, and you can definitely see there was a 6-second pause.
Yep. But obviously,
right. So there was a 6-second pause. This is a horrific looking EKG, and again the question was whether you jump and put a pacemaker on him or not.
But this is
slightly
different, huh? This is a little bit different, and it's provoked.
Exactly. So if you go back and the point is, it's the most useful part is usually the parts before he blocks. So typically, if you go back to the tracings, so here you see the pause, and as you can see, there's marked bradycardia, same as the case Dr. Nadia just showed. But if you go before that, you can see the bradycardia started gradually. So these are the small scale. So you see the rate gradually slows down. You see there, and then until the pause happens. So this part of the EKG actually of the telemetry system, it's the most useful part. It just goes with the point that it was gradual PP prolongation, and then AV block ensues. So this is very suggestive that this is most likely vaguely mediated. And you put everything together, he's in the unit, in the intensive care, and most likely there was suctioning him or doing something for him. He was asymptomatic, and the question, same thing. So this is the point, Nadia tried to just show another example where we know for sure this is a vagal syncope and exactly mimics close to the EKG you just showed. So
yes,
because
absolutely.
people may jump on this and put pacemakers, but this is provoked as you pointed out, and this patient unlikely would benefit from a permanent pacemaker.
So Fethi, can I have a question?
Yes, go ahead.
So you do a tilt study and you know this is mostly vasodilator. You could even just say pacemaker is not going to be an option for this person, huh? Let's say somebody is healthy, comes in with syncope, and you prove this is mostly vasodilator versus syncope, even with this 6 pause seconds, because I have a patient similar to this.
Right.
So the tilt study will tilt you either way, whether you support pacemaker insertions or not, huh?
Well,
No, but equally, I mean, sorry to interrupt. Equally, I mean, the issue with these people is that they have a mixed response. They have both conduction, a very big conductive component, be that we've seen AV block, and then they have a vasodepressor component, and sometimes the majority is cardioinhibitory. Now, issue 3 showed some benefit and I talked about this during the talk in people that are above the age of 40 that have had symptomatic AV block or pauses in excess of 6 seconds. But equally, when they went back and they did a sub-analysis of that study, they found that even those patients that you treated them with a pacemaker, a cohort of them will respond, and you will render them either asymptomatic or you reduce their symptoms. So you take them from being fainters into people feeling dizzy. Whereas you do have a quarter of those people, 25%, who fulfill the criteria for issue 3, they still blacked out. Now, you can't really look at people that have had 20 to 30 second episodes of AV block, complete ventricular standstill, and say, well, I'm not going to do anything. Well, even if you give them Medidren or you give them, you have nothing really else to give them. And you're stuck, really. You are stuck with these patients. They're very difficult to treat. Sometimes it just wears away. It goes away with time.
Yeah, I totally agree with Nadia's comment. And also Yusuf has just also pointed out in the chat box. So these are very challenging, and many of these patients end up having a pacemaker, but unfortunately, not all of them may benefit from it. And they're a very challenging group of patients. And back to the point about the driving, I agree, they happen in clusters, as Nadia has indicated. So typically, I would tell the patient no driving for 3 to 6 months. And then after that, they can drive. Although again, there's no guarantee that may not go back and have the episode of syncope again. I have a comment about the other EKG. Nadia, can I move to that case real quick?
Yeah, sure.
The lady with the myxoma, because I think that was a fascinating case. Just for interest of time. So this one here. I would say this to the audience. If you see something like this, think about pulmonary embolus. Of course, don't think about a myxoma as this, because this is most consistent with a pulmonary embolus presentation as opposed to be the myxoma. This is a fascinating rare case, and again, same thing like S1 Q3, and you can assume the T wave T3, the typical pattern. The question I have, Nadia, which is interesting, as you can see from the image, the strain is mainly on the right atrium. So this is the vena cava, and this is the right atrium. So this is the right ventricle. Right ventricle is kind of small. It's underfilled, if you wish. Mm-hmm. So, so, so I would say, again, I mean, I'm just thinking, how can we electrically, or is there any electrical, I don't know the data, so probably you can update us. I don't know the QRS complex, so this can explain maybe the big P waves, which is atrial, right, atrial strain. Mm-hmm. But the ventricle is underfilled, and we still yet see incomplete right bundle. We see T wave inversion anteriorly. Is there any way to explain this?
Well, one thing I will say is that, I mean, this you're only seeing a still image, but when you're doing it in real time, that mass is going in and out. And I wonder whether the movement, the mass is going in and out. So it's not static like that. It's bumping along between the right atrium and the right ventricle. So, you know, it's giving you a picture of a right ventricular strain as well, along with the right atrial strain. And I think it's probably the cycles. I mean, if you look at the ECGs, there is slight differences in the complexes, not dramatically so, but you see slight differences between the complexes, especially if you're looking at kind of here in lead 2. You see some of the QRSs are a little bit more prominent than others along the way. So I'm not sure if I can add more than that, really.
You know, no embolization to the ventricle, to the pulmonary artery, like there was no PA.
There was no embolization to the pulmonary artery.
By definition, CTA can show you up to the fourth subsegment in the pulmonary artery. So distal embolizations is not, first of all, it's not clinically significant, the patients, except later on in life. And, but objectively, if you want a retrieval pulmonary embolism, CTA is the best test.
Yeah. So we did a CTA, and CTA was negative, and the D-dimer was positive. The D-dimer was positive. So looking at the ECG.
Yeah, by definition, all of myxomas have some phenomena of embolization, because it's go back to the same principle: slow flow, static wall, and you will have an embolization. Her major issue is not the embolization. Her major issue from the echo you showed is the inflow obstruction. And to me, this is one of those emergencies you have to take her like within 24 less even.
Yes. Yeah. So this is a lady who came in 2 o'clock in the morning, came in the night before our kind of surgical MDT. Saw her at 2 o'clock, 3 o'clock in the morning, and the surgical MDT presented her. We got her ready. She had her operation the same day.
Yeah, and for the people who ask about myxoma usually come out of foramen ovale. Pretty much, if it's in the atrium, either it's come from the foramen ovale or from the left or the right appendage of the atrium, but almost all of them that I saw, they come from this area. And for the left side, I put a stitch in the foramen ovale and I cut around it, I eyeball it. It's just there, almost 99% of the time. So it is, from the right side, it's going to be interesting resection, because you've got to try to avoid embolization.
Dr. Mohi, what's your experience with the recurrence? Because we as cardiologists tend to follow them up annually with repeat echoes.
We follow them every 18 months. If you take the base and it's from the atrial appendage and the base is negative, meaning for resection, they will not come back. There is no way they come back. Actually, if you look at their embryo or kind of genetic testing to them, it's more of an embryo tumor than an adult tumor. It's a benign there is no recurrency except if you have an incomplete resection of the base, which tend to happen if you did if it came from the ventricle. But from the atrium, if it's coming from the septum and they did a good resection and reconstruction, it shouldn't come back.
Great, thank you. Fantastic.
Nadia, did you write it up? I think you should write this case up. This is fascinating.
I started and then life got in the way, so maybe I will.
I think people will benefit from it. This is a fascinating case. Mohi, can I ask a question for Khalid Slake, if you have?
Yeah, definitely. Go ahead.
Okay, Khalid. So for the last case, when you have this spiral dissection, you went with the wire. Is there any choices of which wire you prefer, and is there any tricks, like when we try to go through the true lumen, any trick you recommend that a wire you recommend, or any trick to do to make sure that for people who don't have IVUS in their lab, so they increase their chance of getting to the true lumen?
Well, that's a good question, Fethi. For the last case, if you notice, both wires were heart torque Flabby wire. The main force wire is not any specific wire, to be honest with you. So you could get away when you have a dissection with a simple wire. I personally, if I have a problem, think that I'm not going to be able to cross any significant dissection, I will use a whisper wire. But I have to supplement it with an intravascular ultrasound. And if I cross easy, I think, it's the feel of the wire and the freedom you see from the distal tip. This will tell you where in your lumen, and you confirm that with an intravascular ultrasound. And if you have an IVUS, it's really difficult. So it's going to depends on your clinical skills. And one of the trick we do, and I show it in the first case, you put over the balloon wire distally and you inject a little dye. So if you see the dye going into the lumen, that's clearly mean the distal balloon, at least that portion is within the lumen, and you could proceed with your angioplasty. But for the left main dissection, it was a high torque Flabby wire, so we were lucky. But we did not do any stenting or ballooning until we confirmed the positions in the LED and the circumflex was intraluminal. So any wire will be an ideal. Really, there's no major huge difference.
And for the balloon, it was a monorail, right? So
it is a monorail balloon, yes.
So you have to do exchange. Did you put a long wire or just?
No, we duct the wire. So basically, you duct the wire if you know how to duct the wire.
Okay, got it.
Yeah, so you duct the wire, and then you have a longer wire, so you could exchange the balloon easily. Because once you cross that with a wire, you just keep it there. You cannot lose the position. This is one of the tricks too. I mean, right. You cannot lose the position. Once the wire distally, you have to duct the wires, and you go over a balloon, and you inject a little dye.
Right. I think Nadia has a question for you, Khalid. Go ahead, Nadia.
Dr. Khalid, fantastic presentation. Takes lots of guts to get through that without, it's almost like a Brown moment, those kind of moments. But in terms of when you have the dissections and you've stented over them, you put a stent and covered the dissection, do you keep them on something like ReaPro, glycoprotein 2A, 3B? If so, for how long? And do you go back and have a look? So for patients where we've had spontaneous spiral dissections, which are usually distal, we allow them to heal, we keep them on a little bit of ReaPro, and then re-image. Some people will just wait and see how they do symptomatically. What's your approach to? Well,
the first case, when I stented the whole right coronary artery, I usually start loading them with ReaPro. Yeah, so they already, for example, the first one where I decided to stent the whole vessel, I do use 2B3 inhibitors, and that's to reduce the risk of stent thrombosis and improve the flow and deal with the distal embolization. If it's whole vessels angioplasty, and then we keep the ReaPro going with 2 boluses for 18 hours to follow. That's our protocol. Now, if the dissection is really short segment and we could stent it easily and seal it off, main angioplasty, we did not use the ReaPro because we have TIMI3 flow. We confirm with an IVUS, we have a good expansion, there's no residual tear, so we just go with the usual thing, aspirin and Prolenta. That could, so basically it's individualized. If you think the lesion is long, too many stents, you can justify use of free throw. And there is no really study looked at it, I think. In terms of relooking, we go with the clinical picture. So I don't necessarily bring them back in 3 months and recap them and all of the stuff. Basically, I just go with the clinical picture. If they do well, they don't have chest pain, and they clinically stable, I don't take a relook. Now, interestingly, the first patients where they stented the whole right coronary artery, she did present again 4 weeks later with chest pain. Then any presentation justify relooking, and we relooked at the right coronary artery, and she did have in-stent restenosis at the proximal part, which we stented again. So I will say clinical picture is very important. We don't necessarily, we have to look at all the dissections and whether they heal or not in the future.
And which dual antiplatelets are you using? Are you using ticagrelol and aspirin for these patients who, if they had a spontaneous dissection with a coronary cath, or are you using aspirin and clopidogrel?
It doesn't really matter. Any of the either Plavix, Prolenta, or Affiant. We commonly, in my practice, we use Prolenta. This is what we use. Okay, and so I don't think it doesn't matter which dual antiplatelet to use, as long as you continue taking or using the dual antiplatelet for 1 year.
Thank you.
Any more questions for anybody? Okay, this is, I guess we're going to conclude the webinar. Thank you for Khaled, and thank you for see you soon, everybody.